All right. Hello, everyone. Welcome to today's graduate medical education presentation on AI in medicine. And if you're a Hurley resident or fellow, remember to take your post-quiz afterwards on EGME. This quiz, the deadline is actually December 31st, so there's a little extra window for you to complete it. I'm going to turn it over to today's presenters and let them introduce themselves. And yeah, that is it for me. Thank you, gentlemen.
Yeah, thank you, Jason. I'm going to go ahead and start. I'm assuming Len and Jason, you'll acknowledge that my my slides are presenting okay. Is that good? Okay, good. Hi, I'm Gary Ferenchick. I'm a general internist professor of medicine at Michigan State University. And my co-presenter is Dr. Len Fleck, who is also a professor at the University Distinguished Professor, so he can explain that later if he needs to. I am not a computer programmer. I'm, a general internist. I've got a strong interest in, information technology and how it helps us both clinically and educationally. And it's probably been about a year or so that I really started to get real interested in AI, and have developed a little bit of my own personal expertise with this. So I'm going to share a little bit with you today, but share a little bit of what I've learned about that with you today. And then Dr. Fleck is going to be dealing a lot with the ethical aspects of the use of AI. Now, it turns out neither of us have any conflicts of interest to declare. And I wanted to point out co-intelligence. So Ethan Mollick, if anybody wants, if you're even halfway decent with AI right now, if you haven't heard of Ethan Mollick, I'd strongly encourage you to Google him. He's got a book out called Co-Intelligence, which I used a lot for part of my thinking on this talk. And he also has got a free, and that's not free, but it's it's $15 or something like that. He also has a basically a newsletter that comes out about every 2 weeks as well. So he's really a very well thought of person and an expert in this area. So I'm going to talk a little bit about basic concepts and definitions, as you can see up here on the screen, some important theoretical underpinnings. I'm going to talk about some use cases. In some ways, I'm going to talk about how we might, I'm sure it's not currently active, but how we might use it for clinical efficiency. Certainly, I'm using it a lot right now in my educational and curriculum development role, and obviously my own personal life as well. And as I mentioned, Dr. Fleck will be dealing with the ethical parts of this. So just some foundational definitions. What is artificial intelligence? It's the ability of computers to act like humans in solving problems and making decisions in complex situations. Machine learning, and by the way, I put this at the bottom. Sometimes I have little notes at the bottom of my slides. Machine is basically just another word for computer. I don't know why they use machine. It makes it sound really more, kind of mysterious. But it's basically machine learning is a type of AI where computers learn from data to make predictions and offer up certain perspectives on any decisions you might be facing. Neural networks works like a human brain. I'm going to show them my next slide. You can see how do doctors and AI kind of work alike in terms of coming from inputs to outputs. So neural networks is really what AI uses in order to function like a human brain in processing information through different layers of interconnected nodes. These are artificial neurons. Getting back to the artificial neurons, I was told the early versions of ChatGPT had something like 186 billion different connections between the various, nodes within the computer system. Very, very complex and very, very intricate. Deep learning actually relies on these neural networks to learn from very complex data. Right now, AI can do lots of good analysis of photos, for example. You can break down speech. I've actually talked occasionally into my AI, and I also break down text, as you know, as well. And each layer interprets data, passes it in a more refined nature to the next layer, and helping it to basically the computer, the machine, if you want to call it that, understand what it's looking at more clearly. Large language models, these are the advanced AI systems that are trained on vast amounts of data. You heard about being trained on the internet. So many of these larger ones, these large language models actually have been. And then finally, a chatbot is something you're going to use like ChatGPT is a chatbot and Gemini is a chatbot and the like. So these are going to be your entree into AI would be through something called a chatbot. So as I mentioned, AI works much like a clinician. You have basically inputs. We talk about symptoms, take a patient history, of course, through physical exam. AI takes in data, text, images, voices. Considers the pertinence, is this relevant? Is this not relevant? How important is this? Obviously, AI does the same thing in analyzing aspects of data and weighing probabilities and patterns. We use our expertise. We use our, drawing on previous cases and the like. Certainly, AI works much like that as well, looking at patterns learned from the data sets and its primary and secondary learning that it was trained on. We may order diagnostic tests, commonly do. AI runs its own internal diagnostic tests before finalizing a response. And finally, we arrive at a diagnosis. AI revises, basically, arrives at an output. So really, in many ways, this is, not a dissimilar analogy between how we work as clinicians and certainly how AI might work as well. Now, there's currently multiple large language models, chat bots out there. You can see the big one right now everybody's heard about is ChatGPT. You can see the monthly visits right now, 3.1 billion monthly visits. I just got this information just a few weeks ago or a few days ago, basically. And if you take all of the other more popular chat bots together, it's only 388 million. So 90% of all the AI queries currently happening in the world right now are basically going through ChatGPT. So that's the big one, but not to these. I've played around with Claude, Gemini, Copilot. I haven't got into Meta AI yet, but they've all got their strengths and weaknesses. It's just ChatGPT seems to be the one that I've kind of settled on for lots of different ways. Now, I threw this out here because I'm really, obviously we're talking about AI in medicine. So I wanted to go into PubMed. I went in about a week ago or so and just typed in artificial intelligence. And you can see here that there's about almost 112,000 different results. And almost all of those results have happened within the last 2 years or so. And so just, very high percentage of the published data, and some of this stuff is just review articles and stuff. I didn't really narrow it down to, high quality data and the like. Just wanted to see what was out there in PubMed. And you can see that I would say, I'm just going to use my oculometer here, that basically only about 20-30% occurred prior to 2022. About 70 to 80% of all publications have occurred since 2022. So this is, if I did this slide again in a year, it's going to be much higher than that. So it's just coming at us in many ways like a tsunami. So what are some of the core principles? Okay, so first of all, and again, a lot of this is coming from, not exclusively from, but a lot of it's from Maulik's work. This is a dynamic and evolving tool. Things you may have heard about from AI that was ChatGPT 3.5 or so probably don't exist anymore. And anything I'm going to talk about today will probably be different in 2 or 3 months from now. So just recognize that the AI that you're currently using, if you are using AI, will likely be the worst AI you will ever use, because it's amazing, even since I've started to look into this in a much deeper way, how much has advanced in the last year or so. Unlike software manuals or software, there is no single user manual to refer to understand AI's values and limits. Where it works best, where it fails, hard to know in advance. Okay, so that's one of the things you need to understand if you start using AI. And it's also entirely probable, I know it is at Michigan State, and certainly I'm guessing at Hurley as well, that a lot of us are using AI, and we're using it in a much more sophisticated and a deeper fashion than our institutions are. The data science behind AI is incredible. It's quite phenomenal. The implementation science is way far behind, both on institutions like our various institutions, as well as just medicine in general. It's really hard right now even to see where some use cases are currently existing in a much more generalized way with AI. In the people that I talk to, basically. And one of the reasons for that is innovation is quite expensive for organizations, but it's cheap for us doing our jobs, okay? Get into AI, you start to play with it, you realize how it can be quite effective in terms of helping you do your job not only better, but also faster. And that last point there is is probably the most important thing. You get to that point where you realize what it's good for, what it's not good for, through trial and error. And the like, and so it's really personal expertise is really gained in a lot of ways through just getting into it and trying to figure out how to make it work for yourself. AI is a general purpose technology. It's like the internet. It's like Google, basically. It has potential, obviously, and ultimately probably will impact many, if not all, aspects of our life and work. And this is probably the most important thing. If you leave here today with one precept when it comes to this idea of AI, I really want you to think about this. That AI is not meant to replace you, it's meant to basically supplement your work. It augments our thinking. It fosters a collaborative, when you interact with it appropriate, fosters a collaborative relationship, but you have to be the human in the loop. You're ultimately responsible, and that's my last point on this particular bulleted section here, that you need to own the output. I mean, whatever comes out of it, but whatever you're using for it, you pretty much need to understand that it's you that has to make understand what the output is and how to use it in whatever way that it is that you wanted to use it for. So not a big surprise, AI is smart. Interestingly, ChatGPT-4 showed accuracy rates on passing the USMLE step examinations by 80 to 90%. It is demonstrated what these authors refer to as commendable accuracy and adequacy in addressing diabetes-related queries from physicians, basically. It also provided a high degree of accuracy in addressing osteoporosis-related questions that were aligned quite closely with expert opinion in current literature. So there's no question AI is smart. AI can also make mistakes. This is probably the most the most famous one. This is a lawyer in New York City who used ChatGPT back in 2023 to create a legal brief that he then submitted as his own work to the court. The opposing lawyers got a hold of it. They started looking up the case law that this lawyer used to support their contention, and couldn't find any of these cases existed anywhere. What ended up happening was that ChatGPT 3.5 actually gave him fake citations to support the brief that he actually submitted. And this made worldwide news. The lawyer got his hand slapped, as you might imagine, and there was a lot of consequences associated with this as well. Problem was, he didn't own the work. Getting back to my original principle, he got this brief, didn't read it, didn't double check and triple check and do all the things that people would do in order to make sure that what AI is producing is actually true and accurate. And so just recognize that hallucinations exist. It's interesting they call them hallucinations. All they really are errors. They're false results. And Malik talks a lot about AI is more interested in pleasing you than being accurate, right? So if you give it a query, it really wants to say, hey, Gary, well, this is what I'm coming up with, and here's some references, some of which may be true, some of which may not be. And unfortunately, no tools currently exist to identify basically when AI is hallucinating. And Dr. Fleck is going to talk about this as well, but how are AI systems trained? These these LLMs are built on data, and this data, which is in the internet, of course, is can be biased. They can include data that it comes from studies that don't have an inclusive representation of the population. They may not include generalizable data. They may inherit the biases not only of the people that created the content, but also the people that curated it. And then AI, there are humans in the loop before they release it who are fine tuners, right? And these are humans looking at this to try to determine if there's any threat basically to fairness and equity. And one of the things that comes up too is how often are diverse populations actually involved in the design of AI tools? So I do respect this idea that AI is only as good as the data that it's trained on, and only as good as the humans that help do the secondary training for it and the like. So this is one of those issues that I think needs to be in the background as we're thinking about the use of AI. Now, I'm gonna start with the clinical uses because I'm very, very confident that from an institutional standpoint, this is not going on yet. But areas that I think could be most impacted by AI is going to be unshackling us from the EHR, okay? And it's a lot of the administrative work that is, quite frankly, tedious, doesn't necessarily in and of itself provide high value patient care, and helps us spend more time with patients and certainly do things that are more creative and more helpful for patients. And what are some of these things? So I'm really intrigued by this idea of an ambient scribe. And that would be, like I was just in clinic this morning, I could just see there's a microphone basically in the room, and of course patients got to consent to this, and this listening to the conversation that I'm having with the patient. It takes everything I've said, everything the patient has said, and I might have to dictate into the AI what I'm finding in my physical examination, and creates a note. So by the time I get out of the room, there's a note sitting there for me that actually is a true representation, as far as I can tell from the sources that I've looked at, of what has actually accomplished in that room. And it doesn't interrupt with the natural flow of the conversation and the like. was listening to a podcast, not a podcast, but it was a video of Dr. Wachter, Bob Wachter, who's the chair of medicine out at UCSF, talked about, he tried to break AI. He was actually a simulated patient in one of these ambient scribes, and he couldn't do it. He'd talk a little bit about chest pain, and then he'd go off on a tangent. Then he'd talk a little bit more about the chest pain, go off on a different tangent. And AI in that particular situation was able to separate the wheat from the chaff. So I think this is one of the areas that I think there's a lot of potential for unshackling us from the EMR. Chart summarization. I use it now currently to summarize charts in a de-identified way. If there's a lot of information to go through, I might, in a de-identified way, take that information and say, help me make sense of this. I go back into the actual original documents to make sure that it's actually, currently representing it correctly, but it does a brilliant job in terms of some chart summarization. Portal messages, this isn't as much for inpatient work, but it certainly is outpatient work. There are some tools that are currently being looked at to assist with what we call low acuity portal messages that can be dealt with by AI. And then finally, personalized after visit instructions that are tailored to the patient's literacy level, their medications, comorbidities, et cetera. I'm going to tell you, none of these things are currently occurring in any widespread way. But if we're going to get doctors to adopt AI, we have to make it not only easy for them to use, but second of all, we have to make it such that it unshackles us from some of the administrative burdens that we're faced with in terms of our day-to-day patient care. And then I think consent is going to be an issue as well. I put this down here, and we need to learn the best practices and pitfalls for how do we let our patients know that we're actually using this. But a lot of people are saying eventually AI will be embedded in everything, either overtly or in the background. So it's going to be one of those things that's going to be an evolving process. Now, some barriers to bring it to the bedside. I was told that 90% of all AI tools never make it to the EMR, may never make it to market, in part because there's a bad alignment between what people are producing and what's actually needed. This is probably a big one right here. Most institutions require their own IT staff and analysts to implement and monitor and sustain AI in any meaningful way. And that's not just getting it started, it's also monitoring it. There's something called calibration drift that, the data which is trained on may change over time, and the answers it may give may also change over time. And we have to keep an eye out for this calibration drift to make sure it's giving accurate answers given a similar prompt. And then obviously, right now, there's no seamless way for it to enter into our workflows. When I'm using it from a clinical standpoint, it's outside of the EMR, it's on my own computer and all those kinds of things as well. The question is, do docs and patients really want it? And do they trust it? And so those are some things that are going to have to be worked out. So that's, I do think that there's some potential there. I don't know how quickly our diagnostic and management support is going to be there, but some of these backroom or these more administrative tasks, I think could easily be done by AI. If done, in a thoughtful manner. Now, I have some individual and professional uses of AI that I want to go over as well. Now, first of all, how many people are using AI at work? You can see here that healthcare practitioners, it turns out, and this is recent data, this was just published last month, about a third of healthcare practitioners are using AI as part of their work, but only about 1 in 8, 1 in 9 are using it on a daily basis. So it still hasn't really seeped into even individual work amongst physicians, but it's up there, maybe 1 in 8, 1 in 9 and the like. And you can see the differences between different professions here, computer and math professionals, management professionals and all. They all have got different use patterns, but none of these people are using it more than 50% of the people in this survey were actually using it on a regular basis. So it's out there, people are using it, a high percentage, but not certainly the majority. And this report actually suggested, and I would fall into this category as well, that I'm a shadow user of AI, right? I'm using it to make my job easier. I'm using it to make my work and my professional life easier. And it's not formally endorsed at this point by Michigan State, by my college or whatever. And so in a lot of ways, this is one of those things that I think is a uniform finding that many people are actually using it, and quite frankly don't want to talk about it because they don't want to get their hands slapped. They don't want to run afoul of the institutional policies and guidelines and those types of things as well. So there's a whole lot of shadow use of AI going on out there, and I probably would fall into that category as one of the shadow users. Now, if you get into AI, I wanted to talk a little bit about prompting and personas. This is the secret sauce for getting the best out of AI. First of all, AI needs clear instructions. Designing and producing questions that are best suited to get the responses you are looking for is what a prompt is. right? And and I'm going to go through a couple of examples of this as well. And a lot of this is about experience, you go in, the way I learned, quite frankly, I went to YouTube, I looked at a bunch of videos on, how do you do good prompts and all those kinds of things, and started to play around with it and actually found my own path to that. So prompting, as I mentioned, is your question to AI. It's best if the prompt's in context. Quite frankly, if you type in natural language, hey, I want you to act as a professor of medicine, blah, blah, blah. I'm going to show you examples of that. So you want to give some context, you want to give some detail, and you want to give some guidance to maximize the chance that the answer that you're looking for is relevant, accurate, and aligned with what you need. Now, the persona is what you ask the AI to do. As I already mentioned, I want you to act as a professor of medicine. I want you to be supportive. I want you to act as a technical expert. I'm told, I don't write code, but I'm told AI writes phenomenal code. I want you to act as an expert, computer programmer and those types of things as well. So you want to tell it what it is that you want to, how you want it to act. So here's a prompt that's not that great. Tell me about lupus anticoagulant. Okay, a better prompt is, I want you to function as a professor of medicine. I'd like you to explain this lupus anticoagulant at the level of a first-year student, giving a lot of context. I want you to focus on defining it is, what the actual abnormality is, why it's important, what are the common findings, how to diagnose this. I want you to use simple language. I want it to be brief, under 200 words, and I want you to give me that information in a bulleted format. So you can see the difference between the two prompts in terms of the content that you might get as a result. And I'm going to show you how back and forth works, because the next prompt I'm going to show you, many of you are required, quite frankly, to do research projects or to engage in some scholarship. So I was on the clinical service at our local hospital in August, and one of the things I realized is that we get daily labs on everybody, right? And at times I'm looking and saying, why are we getting daily labs on everybody? Not everybody needs daily labs. So in preparation for this talk, I thought, well, let me think about designing an experiment using ChatGPT to try to answer the question, can we identify those patients who are more versus less likely to benefit from daily labs? So this is me talking to ChatGPT 4.0. So ChatGPT 4.0 means optimized, basically. That's what I have down here. It really is a research design prompt. So here's my prompt, okay? So this is me talking to it. It says, I want you to act as an expert in internal medicine research design. I'm a doctor who regularly rounds in the hospital taking care of adult patients. I've already set the daily lab issue. I'm interested in doing an observational study. Who does and doesn't need these daily labs going on? I only have a 2-week period of time. That's why I basically kind of bolded it there. And I want you to assist me in setting up a research protocol, blah, 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 blah. I get to the very end, and this is part of what I have learned to use AI for. Before getting started, do you have any questions for me? I'm asking AI to say, hey, of all this stuff that I've given you here, do you have questions for me that I can help clarify? So this is me talking to ChatGPT. This is the exact prompt, by the way. This is what came back. So this is ChatGPT responding to me right back. It probably took 10 seconds. Okay, so thank you for the detailed background. I'd love to assist you in setting up this study. To ensure we're aligned on objectives, I do have a few clarifying questions. So it goes on to ask me about the study question, the outcomes, what outcomes are we looking for? What kind of data am I gonna have available? What kind of sample size am I looking for? And then it tells me at the bottom, once I have this information, I can help you focus a protocol that optimizes for time and data richness. So it comes back to me. So I then am responding back to ChatGPT. I said, oh, this is great. Thank you for asking these questions. I like blah, blah, blah. I'm not going to go through all this. But anyways, this is me now in an iterative process working back and forth with ChatGPT to try to get the outcome that I'm looking for. I want a good research design, okay? So I answered ChatGPT's questions there. And it says, oh, perfect. This helps me clarify. Again, this is talking back to me. Here are some ideas to refine the study protocol based upon your goals. So it gives me a study question there. It gives me the population, both inclusion and exclusion criteria. It's defining what is the utility of labs. So it goes through some definitional elements there. And then I put an arrow. You can't quite see it on the slide, I don't think, but down there, it gives me a lot more information. I didn't want to go through this entire thing because that's not the point of this. But I wanted to show you the type of detailed information that it gave me here. So that was ChatGPT 4.0. Then one of the issues that comes up with any large language model, any chatbot, is how do you know, how can you become confident that how it got to its answer? And that is showing you its work, right? So just about 2 months ago, ChatGPT has intermittently made this ChatGPT 01 preview available, and I fed it the exact same prompt, and I wanted to show you what it came up with. The reason I bring this up is because there is that precept that I talked about early on, saying that this is the worst, AI that you're going to be working with. It's going to continually evolve. So some of the problems that have existed with older versions of AI are now being addressed in a very substantial way. So I gave it this, basically gave it the same prompt. This 01 is designed to enhance transparency. It provides step-by-step explanations of how it arrived at its answers, and it really helps us as a user understand how it gave a certain output. Remembering, of course, this is a dynamic and evolving tool. So I went through this entire thing. It gave me roughly the same type of output. Then I said, well, how did you actually come up with this? So there's actually a button that you can push within it right now that gives you a step-by-step transparent, text here to show you how it came up with its final product here. So this is really crucial for trust, for transparency, and for accountability. So again, this is not widely available yet, but it will be at some point. And this isn't just for research questions. I would say anything that you come up with. It might be a clinical question, and you click that little button, it'll tell you this is how it's come up with the actual answer. And this is what it came up with. A really nice. All I did was copy and pasted it. This is a really nice, formatted, a product here. Study questions, secondary research questions, et cetera, et cetera. So I know many of you are either actively engaged in research or soon will be. And I'd really encourage you to think about using ChatGPT or one of its equivalents for helping you set up the study design. Another way that the current version of ChatGPT is actually enhancing transparency and accountability is telling you where it got its information from. So before, there was no reference. It just came up with stuff and you either believed it or not. So now you can actually ask it to search the web. Prior to about a month or so ago, it didn't. And it also gives you specific references for answers, for the queries to your answers. I've become a big fan of apolipoprotein B and cardiovascular risk assessment. And I asked it that. I said, give me some of your recent guidelines on apolipoprotein B in clinical use. It summarized it up here. It gave me the exact reference. When I clicked on that, it took me right to the article. So anyways, long story short, there are ways to enhance some of the transparency of AI. So a couple of other use cases. I had a patient using your oculometer. You'd look at her and say she needs a motorized wheelchair. She had bilateral amputee. She had a stroke in the past. She got denied by Medicare. I ended up saying, okay, give me the 25-page Medicare booklet on what it takes in order for somebody to qualify for a motorized wheelchair. I fed it to ChatGPT. I set it up. I said, basically, I've got this patient de-identified with all these characteristics. I went through my prompt. Here are the criteria for which Medicare will either approve or not approve a motorized wheelchair. Can you help me craft a letter? It just killed it. Just absolutely killed it. Did a great job on that. That would have taken me hours to read through that, to try to figure out all this kind of stuff. It did a terrific job. When I first started using ChatGPT, I'm also an attending on the inpatient ward. We have obviously our morning reports where there's an unknown case that was presented. So last December, the resident went through this case. Turned out, I'm going to cut to the chase real quickly. It was a rare manifestation of a rare illness. It was a paraneoplastic cerebellar degeneration, right? And nobody in the room got it. So at the very end, everybody's, oh God, that's so interesting. So I got home that night. I said, I wonder how ChatGPT would do with this. So I asked the resident to send me the PowerPoint. So I progressively added the information. I told it what I wanted to do. It came up with a diagnosis. So I don't need it to help me make a diagnosis of urinary tract infection. But when people are presenting with symptoms that are, obviously symptomatic, and you don't know exactly what's going on, this could be get you in the ballpark type of a thing. I'll look up quick facts. I'm doing a lot of precepting right now for second-year medical students. We're talking about vasovagal syncope. I couldn't quite remember the neurogenic mechanisms of that, so I just type it in. I'm a professor of medicine doing this with second-year medical students. Can you catch me up to date on the neurogenic reflexes that happen when somebody faints, basically, when they have a vasovagal syncope? I do use it for summarizing chart information, protecting a PHI. It probably saves me at least 50% of the time to do that. I have actually asked it to help me create some quick text as well. One I just used this morning, actually. A patient came in and said, I'm not sure I'm thinking well, and those kinds of things. So I did a cognitive assessment that I actually created with the help of ChatGPT. I said, help me create a really nice quick text in my EMR that I can actually use to do a cognitive assessment on patients. And again, I looked at the original research and all that kind of stuff. I was very happy with it. It was well organized, and it actually worked quite well. One of my wife's grandsons, I had mono, big soccer player. Hey, when can I return to play? I couldn't quite remember, so I actually asked it that. And I was down in Florida about a month ago and had a horrible case of norovirus. And I said, how long am I infectious for? So just little stuff like that, you can kind of get some really interesting, and quick information. Again, low stakes. It's not going to harm anybody if it's slightly wrong, particularly this one. I had a patient come in and said, to what degree are males contributing to the BRCA gene? I had no idea, right? And so he said, could you send me some information on this? So I did help ask ChatGPT to give me some assistance in understanding the genetics of the BRCA gene and to what degree do males actually contribute to that, because it wasn't apparent to me. So he was much appreciative of that. As in my other professional role as an educator, I created probably 100 multiple choice questions with explanations using ChatGPT. We're involved in a curriculum mapping process here, and I've used it to help me map not only our objectives, but we have to map them to something called educational program objectives, which are things that we expect our students to actually have at the end of our curriculum. I just created a couple of PBL cases a couple of weeks ago. One of the basic scientists says, hey, can you help me create a couple of PBL cases? Did a really good job on that. I do some podcasts every other week, primary care update. I ask it to say, hey, I do these podcasts. I really need a review of this article. This is what I want you to accomplish. Again, my prompt is quite long, and it does a really good job. I go back into the article to make sure that what is given me is actually accurate. But for the most part, it just saves me a lot of time in reviewing and summarizing articles. Doing some neurological stuff with medical students right now. I couldn't quite remember what the spinal thalamic tract is. I should, but I didn't. I went in and kind of looked at that. The other thing, some of you who are attending on this, are asked to do letters of recommendation. I've done 2 in the last 6 months where I have my own individual observations of the learner, the student, or the resident, and I ask them to send me their personal statement. I do a little bit of interview with them and add it to my stuff and ask them to send me my CV, add all of that into ChatGPT and ask it to actually create a draft, and I obviously edit it, of letters of recommendation, which again saves a lot of time, and they're usually extremely well written. Okay, so personal uses. I was in France last summer. I had no idea how to use the washing machine because it was all in French. And so I took a picture of the control panel, uploaded it to ChatGPT, and says, help me understand this. Did a great job. I am learning French, so I'm creating tests for myself, creating some content. I'm not a big chef. Sometimes I like to cook and have people over, so I'll say, I have this number of people over. I'm thinking about this as a possible kind of a menu I want to put together. Can you give me some ideas of not only what types of food I can include, but how much? For some reason, I couldn't organize my Gmail by from, and so it's just a very simple inquiry just in the last week or so. I said I need to find this email, and I couldn't figure out how to do that. Just gave me that. Creating a music playlist by theme or genre. Summarizing, I'm a big fan of this gentleman called David Goggins. So I said, hey, could you summarize some of the key points from his book called Can't Hurt Me? And again, it gives me a really nice summary of what he's really talking about. So I'm going to turn over to Len here in a minute, but a couple of quick things. The STFM, which is the Society for Teachers of Family Medicine, has developed, and this is where I listened to Dr. Bob Wachter's videotape. And if you type in, I just practiced this yesterday, if you go to Google and type in STFM developing AI, of course, there's going to be 3 or 4 or 5 sponsored sites that are going to come up first. It's the first non-sponsored site. It's free to anybody, so you don't have to sign in. You just listen to them. And it's I listened to the first module. 2 and 3 are coming up in the next couple of months. And then I mentioned that Ethan Mollick's book, Co-Intelligence, is really a brilliant book. It's about a year old, so he even acknowledges up front that that what he's talking about now is not going to necessarily be the case when you're listening to his book, but he's a very bright guy, and I want to give him a shout out there. So final thoughts before turning it over to Len. Iterative learning and adaptation, the more you use it, the more you're going to realize how you can use it, what it's good for and what it's not good for. Ultimately, governance is going to be a big issue if we try to incorporate this into what we're doing on a professional basis, particularly with patient care. Think about AI as a thought partner, not as a thought replacement. And it's really easy to copy and paste and just not look at it. You almost have to be disciplined about, okay, this is a draft. Think about AI as being a really smart graduate assistant who does really good work, but is really wrong sometimes, but you don't know when they're going to be wrong. And so you have to go in and actually, check on their work. And then obviously there's still some issues of what do you want to call it? Just bias embedded in some of this information and data that we just need to be aware of and understand that there may be some limitations of what it's giving us. So I'm going to end there. I think, Glenn, I left you enough time. You said you needed about 20 or 25 minutes. So
yeah.
Let me go ahead and turn it over to you. Did I stop sharing here?
Yep, you did. I'm
Okay.
going to go to my window and I'll go there. I'm going to hit share. And let's see if this is working now. Is everybody seeing a clear picture? Okay. So let me introduce myself again. I'm Len Fleck. I'm a philosopher, bioethicist, not a physician. And I'm here in the College of Human Medicine. If you guys were paying very, very close attention to Dr. Ferenchick, you're not going to have to worry very much about the ethics issues. If you're a little bit distracted, then you want to pay attention to some of the kinds of things that I'm going to talk about here. So we start off with the fact, we're going to talk, first of all, a little bit about your anxieties, which are more about self-interest than ethics. So you got these technological breakthroughs, which have the tendency to inflate our desires rather than make people more rational. And so oftentimes by the time some of this technology has been widely disseminated, then our ability to actually control what happens with that dissemination is extremely limited. And consequently, we end up with this question, what should we do? Is AI the HAL that we feared in Space Odyssey? Just to remind you of what that looked like. I'm sorry, Dave. I'm afraid I cannot do that. That was really a frightening piece of filming that occurred back in 2001. So here are some of the fake news things. There's concern among at least some physicians that AI is really just going to take over medicine. Radiologists, it seems, are especially vulnerable to this particular anxiety, that they won't be needed, that AI will do all their work, and that they can just go off and play golf or find some other occupation. We have to ask whether the use of AI in clinical practice is going to be analogous to self-driving cars with the physician in the back seat. If you're paying close attention to Dr. Ferenchick, then you know that is not how AI is supposed to be used. As physicians, you're supposed to remain in the front seat in control of how AI is going to be used. So we're concerned about some of the ethics issues associated with AI, and we want to know that AI is going to be used in healthcare in a responsible way. So that's the first ethics norm, that it's evidence-based, that it's bias-free, and that it's designed and deployed in order to promote equity. And so if AI systems are not examined for ethics and soundness, then they can be biased, as Dr. Ferenchick pointed out, and can make even worse existing imbalances with regard to socioeconomic class and so on. And then some people are going to say, well, why not just embrace the idea of letting 1,000 AI protocols bloom in the clinic and then throughout medical practices? And the problem is there's probably going to be a lot of weeds among those blooms, and some of those are going to have kind of mesmerizing hallucinogenic properties that are going to result in misuse of that technology. So here would be one of the positive examples about the use of AI and the question of whether or not it might really be a Pandora's box. So Alzheimer's related neurologic degeneration begins long before the appearance of clinical symptoms. And so information provided by functional MRI, neuroimaging data, which can detect changes in brain tissue during the early phases of Alzheimer's, holds potential for early detection and treatment. And so researchers are combining the ability of functional MRI to detect these subtle brain changes with the ability of machine learning to analyze what that's going to mean over time. And this approach aims to improve the early detection of Alzheimer's disease, as well as other neurologic disorders that can include schizophrenia, autism, and MS. But on the downside, among other things that AI can be used for, is that, as this one researcher points out, for less than $100,000, it may now be possible to use artificial intelligence to develop a virus that could kill millions of people. So there are these very positive uses of AI, and then there are these horrific possibilities with regard to the use of AI. Some additional thoughts. We got to be honest with ourselves. We already rely on artificial intelligence in lots of ways. We rely upon something called smart watches to monitor our health from minute to minute. And one of the things that caught my attention is that these smart watches are not marketed as artificially smart watches. They're just flat out smart watches. And then it's pointed out, Google handles 1 billion questions every day related to our health. And we have to ask, does Google get it right 1 billion times a day? Probably not. So we have to pay attention to that. One of the problems with AI, especially when you get into deep learning and the neural networks, is the so-called black box problem. So doctors are raising more questions as they attempt to deploy the roughly 350 software tools that the FDA has already cleared to help detect clots, tumors, or a hole in the lung. They have found few answers to basic questions. Among other things, what they're really concerned about is, how is this program built? How many people is it tested on? Is it likely to identify something a typical doctor would miss? Those are the critical questions that need to be asked. And this is the black box problem in brief. Billions of bits of information can be processed in seconds by AI, hooray for that. And AI can engage in this deep learning that improving what it's designed to do. But clinicians using the technology have no idea how the program was built, what the consequences of testing it were, how reliable it is when AI learns something new that might either trigger numerous false positives or it misses things that a clinician would usually pick up on. So deep learning is widely used in medical AI, and it performs very well in terms of things like medical imaging analysis and clinical risk production. But explaining deep learning-based medical AI is almost impossible, which is related then to the connection complexity and the mathematical abstraction of some of these deep neural networks. People cannot explain how the machine makes judgments, though, as Dr. Ferenchick pointed out, in some cases, you can get an explanation of sorts from AI if you ask the right sort of question. And so then we're, as a physician, as a clinician at the bedside, you might be faced by something like this. See, there's this little black box we rely on. It's sort of like a computer. Well, lots of stuff happens inside of it. Then we have a diagnosis. Well, that's not exactly what we imagine shared decision-making is all about as far as ethics is concerned. So here are the 5 big ethics issues that are related to AI. First of all, who is going to be responsible for AI-related mistakes? In a court of law, could you just point to the computer and say, that made the mistake, sue it, not me, or to those who designed the program? And then how do you integrate human intelligence with AI intelligence? And then should AI handle an end-of-life decision? So there's lots and lots of complex things happening when you're faced with a terminally ill patient, and how aggressive you want to be and how much it makes sense and so on. And so should lots of those kind of questions be fed into some kind of AI mechanism, and to what extent should physicians rely upon what you get as advice from that use of AI? And then how do you, as Dr. Ferenchick pointed out, how do you ensure that AI doesn't perpetuate healthcare disparities? And how do we avoid AI increasing injustices in the healthcare system with regard to the allocation of healthcare resources? I'm going to give you some examples of that shortly. And then, will AI inhibit the ability of patients to make autonomous choices through the process of shared decision-making? And it seems like that is related to the black box problem we talked about. So here's a scenario for you. Imagine a patient 75 years old with a hematologic cancer such as lymphoma that has failed 3 courses of therapy. They now have the option of CAR T-cell therapy with a front-end cost of $475,000 and another potential $200,000 to address the side effects, neurotoxic or cytokine release syndrome side effects of of your CAR T cell therapy. One of the things we know statistically is about 30 of those patients are not going to survive a year with this therapy. Keep in mind that one of the really big focal points of healthcare policy analysis these days is healthcare cost control. And so if you're looking at a front end cost of $475,000 for a patient that's not going to survive a year, that's going to get somebody's attention. But the problem as things are now is we don't know who's in that 30% group, but we may be able to use AI in the future. In fact, I'm sure it's going to be used in the future with an AI algorithm that can predict with 90% certainty who's not going to survive that year. And it's very easy to imagine that insurance plans are going to build into their, an insurance company is going to build into its plan a requirement for having such testing. And they're not going to pay for those patients who are in that 30% group. So the ethics question for physicians and hospitals is, should they accept that AI-generated economic medical reality? And then who should have the legitimate authority to decide that? What kind of a decision would be a reasonable, fair-minded kind of choice to make in that circumstance? Or here's another one. We're not that far out from COVID. So imagine a 69-year-old patient on ECMO for the past 27 days. An AI algorithm predicts this patient has only a 10% chance of surviving on ECMO, though they might survive another 2 weeks. ECMO circuits are extremely expensive because of the high staffing requirements. There's this other patient, 67 years old. He's going to need that ECMO circuit within the next 24 hours. That patient, per our AI algorithm, would have a greater than 50% chance of surviving that hospitalization with ECMO. And so the question, the ethics issue, would the ECMO director be ethically justified, given results from application of the AI protocol, in removing that first patient from ECMO in order to make that circuit available for the second patient with better prospects? Why or why not? Do we use the rule first come, first serve? Is that the end of the story? And so our 69-year-old patient gets to stay on it, even though he's very likely to die within the next 2 weeks. And how in the world should we make that distinction? So there's a lot of hype that's associated with AI and what it can do by way of using complex ways of integrating medical data to assist with either with making a diagnosis or with therapeutic recommendations. But here are some critical questions. AI may be able to detect very early pre-symptomatic stages, like with our Alzheimer's disease example, of various chronic degenerative conditions like heart disease, cancer, diabetes, and so on. But then this raises what a health policy analyst refers to as the doing better and feeling worse problem. Early detection of any of these conditions does not mean cure most often. It just means a multi-year prolongation of early disease stages, oftentimes at very high drug cost, $20,000 or more per patient per year. And if we imagine that 20 million Americans might need such care per year because of this early diagnosis or early identification of an emerging chronic degenerative condition, that'd add $400 billion to the annual cost of healthcare. And then we run into the question, well, would everyone be covered? What about copays, deductibles, disparities, and so on? And the other thing that is going to emerge is that if AI is extremely good at teasing out the implications of genetics and lifestyle choices, is there going to be a greater demand for personal responsibility of costs? And will physicians be expected to be the enforcer of those social expectations? In other words, denying people financial coverage for some of their conditions if, in fact, their condition is judged to be a product of bad healthcare decisions they've made, and that they were warned by their physician through the use of AI that they should alter their lifestyle choices. So patient populations are diverse, and so you've got the problem of intrinsic uncertainty. So individual differences in drug metabolism can give rise to serious side effects in some patients, but they can be life-saving in others. And then women with myocardial infarction have a clinical presentation that's different from that of men. And so the problem is AI models anchored on population level accuracy metrics risk undervaluing lots of subtle differences among individual patients. And so even though the AI protocols may be accurate on average, they don't provide reliable evidence for all individual patients. And so when a patient inquiring about their own health asks their clinician, "Are you sure?" Such AI tools cannot consistently provide an accurate answer. And so you have to be able to convey the uncertainty that's associated oftentimes with AI. AI, because of the black box problem, involves a certain amount of opacity. And the opacity means that there's a potential for a risk of harm. And then the question is, how are you going to deal with that particular risk of harm that might be generated? And then I'm going to go quickly through some of these. One of the other uses of AI with regard to cancer care is the use of what's called artificial empathy. So the argument of some writers is that artificial empathy has the potential to strengthen cancer care with support during diagnosis, treatment, and even survivorship. And it may improve clinician well-being by helping to ameliorate compassion fatigue, which is particularly high in oncology, by enabling clinicians to focus their empathic interactions where they are most needed. And so then the question is, what are some of the limitations that are associated with artificial empathy? Well, it may inadvertently result in less human empathy in the oncologist-patient relationship, because genuine empathy requires a certain amount of emotional effort. Secondly, there's the risk of furthering inequities in cancer care, because maybe you provide the artificial empathy to patients who are not well-resourced, who are financially less well-off. And the question is whether or not that represents something that's inequitable. And there's also the risk that artificial empathy might alienate patients who are often faced with one of the most worrisome diagnoses in their life. And artificial empathy may reduce the intrinsic value of empathy. So here's an example of genuine artificial empathy. So what you have to imagine is this conversation taking place. "Good morning, Ellen. I like your sweater. It's very becoming. I'm here to provide you with your daily dose of supplemental empathy. You seem surprised. Your oncologist is suffering compassion fatigue today, but I can offer you unlimited compassion. Let's get started. I have a busy day." Then the last thing I want to bring up, because I want to allow time for questions and I want to get to my take-home messages: bad data, corrupt data, deliberately falsified data, all can yield bad outcomes, bad clinical recommendations, bad diagnoses. And a question that physicians are faced with is, how are you supposed to know that the data included in that black box is biased, corrupted, or falsified? Dr. Ferenchick said, well, you put into your prompt, "We want the most recent data from respectable medical journals." Presumably, we can all identify which journals are the respectable medical journals. But even in respectable medical journals, there is fraud that sometimes occurs, and it's sometimes missed by the editors of those journals. And so data quality is a problem. And then I want to flip through all the way to the limits of AI medicine. It needs human surveillance. This is a point that Dr. Ferenchick emphasized very strongly. It may overlook social variables, all kinds of social context things occurring in the lives of individual patients. Inaccuracies are still possible. And so a physician has to be attentive to what's going on and continue to rely on their own experience and clinical judgment. There are challenges with data sharing because there's all these issues about intellectual property and data interoperability. These are sometimes financial issues that the providers of this AI expertise are concerned about. There are the bias and fairness issues we mentioned. There is the problem of the regulation and evaluation of AI applications. So two big problems are rapid changes in the AI devices and the data material used, which makes evaluation of the output very difficult. And then there's the transparency and reproducibility issue, which is going to be very problematic if you have the black box problem. Ultimately, the problem is explainability, which seems to be essential for application in clinical practice. And then finally, there's the issue of reimbursement. Who in the world is supposed to pay the cost of using this technology when right now, at least, there's a lot of uncertainty about the value of the output as well as the non-transparency, the black box issue. And so right now, insurers don't seem terribly interested in accepting that. So there ought to be, the final conclusion is there ought to be rigorous testing of all AI interventions, no exceptions. There should not be exceptionalism for AI in medicine. It does require rigorous study. Responsibility for the use of AI in a clinical setting start with and ends with the clinicians using that technology. There are no rogue gremlins, ignorant gnomes, vicious viruses, mutant bacteria, evil electrons, or nasty neurons to blame for the bad outcomes if you're a poor user of that technology. And I'm going to stop right there. Lots and lots of references. You can get a hold of these slides through the AI, through your office there at Hurley. Thank you for your time and attention. And
all right, thank you very much. If anyone has any questions, you can either enter them into chat or ask them now. All right, it doesn't seem that we have any questions. So I just want to thank you, our presenters from Michigan State, and remind you once again, if you are a resident or fellow, please take your post quiz on EDME. And again, the deadline for that is December 31st. So you have a little extra time this time around. All right, thanks again. And I hope everybody has a good day.